All right. Well, thank you so much for having me. It's such a privilege to be here and see people in person after so long. Go ahead. Okay. All right. So I know all of you are probably as sick of hearing about COVID and talking about COVID as I am. But another way of thinking about this is that we're actually privileged enough to be here 2 years later still talking about this. So I appreciate your patience at the end of the day. As always, this is really not meant to be personalized information for you, but some big picture general concepts and presenting some of the data that we have so far that may be more applicable to people with IBD and give you a broader sense of some questions to ask your providers specifically and how to think about this in the context of your overall health. So over kind of hopefully just 15 minutes, we'll quickly cover a big picture IBD and infections, as well as discuss the epidemiologic data that we have to date, talk about the data on vaccinations in people with IBD, as well as a quick overview on the available treatments and sort of moving past that. So you all know, I'm sure, that IBD is this complicated disease process, a complicated interaction between a genetic predisposition and various environmental factors, some of which you've already heard about, which ultimately culminate in this uncontrolled immune response, which seems to be a hallmark of this disease process. And so partly because of this uncontrolled immune response, but perhaps because of other factors too, it's kind of well known that patients with IBD are at an increased risk for infections. So we knew this clinically for a very long time, but this is a forest plot from a UK study that included almost 20,000 patients with IBD and compared them with age, sex, and comorbidity and a number of other matched non-IBD patients, nearly about 80,000 of them, and really showed very nicely that patients with IBD had an increased risk of nearly every infection they looked at, perhaps with the exception of herpes simplex virus. So this has been well known, and so you can imagine that in March 2020, as we were starting to really think about the pandemic in the United States, we were really worried that our patients with IBD were going to be getting COVID-19 at much greater numbers than the general population. We're worried about patients with immunosuppression having this increased risk for this novel infection. And so I was rounding on the IBD service in our hospital toward the last 2 weeks of March 2020. And very interestingly, it was the lowest census we've ever had on the IBD service at MGH. And that's probably a number of factors. And the only patients who were hospitalized with IBD in the last 2 weeks of March at Massachusetts General Hospital were patients who stopped their own medications because of a fear of a pandemic, which you can imagine is actually kind of natural when we knew nothing about this new infection. So this is data that we put together very quickly because we knew that there were ongoing registries globally to look at outcomes in people with IBD when they had COVID-19 infection. But what we didn't know was, were patients with IBD getting COVID-19 at greater or lower numbers than people who did not have IBD. So at a time when the population prevalence of COVID-19 in Massachusetts was 1.1%, in the Massachusetts area, we learned that only 0.7% of people with IBD had a COVID-19 infection, either by diagnosis or positive test. And so this was somewhat reassuring, but this could certainly be explained by a number of other factors, including the fact that it's reasonable to consider that patients with IBD were taking greater precautions from getting COVID or isolating themselves or whatnot. So there's a number of other things that could really be explaining this. But later on, more recently published is data from the Secure IBD registry, which is one of the earliest registries that really got off the ground with very strong kind of epidemiologic methods to look at outcomes in people with IBD. The one big downside of this registry is that it involved reports. So the doctor had to report a patient at least 7 days after an infection so that there was adequate time for outcomes. So you can imagine that there's a lot of selection, and it involved additional work on an already sort of constrained healthcare system. So what this shows, though, and this is only updated until July 2021, but it really shows that the patterns of IBD, patients with IBD getting COVID, were similar to that of the general population. So there was no real reason to believe that COVID was an especial threat to patients with IBD more than the general population. So that's, one good factor. That being said, we still worry, right? And so the other thing we learned from the Secure IBD registry is that poorly controlled IBD is actually the greatest, or one of the greatest risk factors for severe COVID. So in this study, they defined severe COVID as requiring a hospitalization in the gray bars, or being in an ICU, requiring a ventilator, or unfortunately even death. And PGA is physician global assessment. So when you fill out a case report form in the Secure COVID registry, they ask for this physician global assessment of their overall disease activity. So it is very subjective, but they ask us to classify people as, mild IBD, moderately active IBD, or severely active IBD. And those who had moderately or severely active IBD were actually at significantly greater risk for having a bad outcome with COVID. So this was actually very reassuring for us, even early in the pandemic, to say we really need to keep your IBD under control, and stopping your meds, even though it's immunosuppression and there's this infectious disease global pandemic going on, is not actually the right thing to do. So this was very early data that helped reassure us in these decision-making processes. And then later on, the Secure IBD registry joined hands with some rheumatology registries where they used similar types of medications. So they looked specifically at anti-TNF agents like infliximab and adalimumab, as well as immunomodulatory agents like thiopurines and methotrexate, and JAK inhibitors, which are used a lot more in rheumatology. So things like tofacitinib and newly upadacitinib for us. But in what they found in this study was that perhaps anti-TNF monotherapy, or using infliximab or adalimumab alone, not in combination with another immunosuppressant, may be more favorable in terms of a decreased risk for severe COVID. You'll also see, and this is a very small a chart here, but they did separate out the Secure IBD registry, so looking at IBD patients specifically versus the rheumatology registries. And so you'll see that there's minor differences, but overall the big picture is that anti-TNF agents are not as dangerous for a risk of severe COVID as it seemed like they could be in March 2020. But I point this out to all of my patients. The worst thing for COVID, if you're someone with IBD, is really being on corticosteroids. Now, this may be the case for other disease processes too, I don't really know, but this is again from the Secure IBD registry, and they broke it down. They broke down the risk of severe COVID by type of medication, and I highlighted the systemic corticosteroids and even the budesonide for each category. And so you have the greatest risk of hospitalization and death, severe COVID, and again, they looked at death separately with corticosteroids and budesonide. So this is, I think, a very big point to take home, which is that while the immunosuppressive medications that are used may seem dangerous in terms of a risk for getting COVID and having severe COVID, steroids are way worse. So the alternative is the steroid-sparing immunosuppression that keeps the disease in check. As with other people with COVID-19 infection, we also see in patients with IBD that comorbidities like cardiovascular disease and kidney disease and such confer greater risk for getting COVID and having more severe COVID. So that's also not surprising. And again, paralleling what we've seen in the United States with the COVID-19 pandemic, as well as sadly other disease processes overall, Hispanics and Blacks do have a higher odds of a worse outcome with COVID in people with IBD as well. So this is also, again, from the Secure IBD registry. So you all know, I'm sure, that there's a number of tests for COVID. There's the, rapid home antigen test that I think everyone is used to, and certainly every little kid is used to. And so there's also the more laboratory-based tests like the PCR testing. There's saliva testing available. Saliva testing is not as sensitive or specific yet, but certainly probably a field that's going to develop more over time. So we don't need to, I think, spend too much time on that. But I think it is worth, talking about the COVID-19 vaccines still. So I think it's just important to take a bigger step back and talk about, what are vaccines on the whole. So you have these cells in your body called B cells and T cells, and simplistically, since I'm not an immunologist, I like to think about them as your body's sort of like ninjas, security, the police, army, and the various things that these B and T cells do are to patrol your internal systems to make sure that they're all kind of working right in the way that a police might, and then to patrol the external environment outside your body to make sure that there aren't any active threats in the way that an army might. And so it's obviously very simplistic, but vaccines are army training exercises. So what I really like to say to my patients is that, just as you would not want to have an untrained police officer or an untrained army, which we certainly don't allow in the United States, we shouldn't really have an untrained army and police in your own body. And so vaccines are really kind of the way that we train this army and police of your body. And many people, when they're training, they look like this. If you're like me, you kind of look like this when you're training. So it's not really a pleasant experience, but whatever, because the end point is really that you feel like this, right? So it doesn't matter how you look while you're training. The end point is that you're trained. And that's really what vaccines are there to do. So just as having a trained army and trained police, it doesn't mean that bad things aren't going to happen. It doesn't mean that there aren't active threats. It just means that your ability to handle them and mitigate them is much higher. So we have these phenomenal vaccines for the COVID-19 infection, and that's really been kind of a miracle, not just of science, because I think the science has always been there, but of collaboration. And so I think that's very important to recognize. So the mRNA vaccine platform has actually been around for quite a while, but it really sort of came to light with this infection. So I'm sure you all know that the Moderna vaccine and the Pfizer vaccine are the two mRNA COVID vaccines available globally. The primary vaccination series is considered 2 doses. And then in the general population, so people without any immunologic conditions or immune suppressing medications, it's recommended that you get a booster sometime about 5 months later. And then for people over the age of 50, a second booster about 6 months later. And then there's sort of a timeline for what may be recommended for people with immunologic conditions and immune suppressive medications. The definition of that can vary a little bit, actually. But the idea is that you get 2 doses, and then a month after your second dose, you get a third full dose. And that distinction really matters mostly for the Pfizer vaccine, for the Moderna vaccine, because the booster is actually half a dose. And then kind of 4 to 6 months later, you get a booster dose. And I've been getting a lot of questions about a second booster lately, and I do think it's worth getting a second booster 6 months later when you're on immunosuppressive medications specifically. And this is a schematic from the Mayo Clinic website, I believe, that basically shows that the mRNA vaccine is basically a protein that is injected into your body to train, again, train is the key word here, your own cells to recognize the antibodies, so that they're literally training your army to say, hey, I know you and I know how to respond to you. So you may still get an infection because, that's, again, what can happen, but at least your body's army is now more primed to fight this infection, and your outcome and your chance of having severe infection is substantially lower. There is this viral vector vaccine, which is actually really cool technology too, but the CDC has actually issued a formal recommendation that an mRNA COVID-19 vaccine is preferred. I had a couple of patients earlier on in the pandemic, or as soon as the vaccines were out, who elected for this vaccine because it was a 1-dose vaccine. It seemed kind of reasonable back then. As the outcomes with vaccination have been published, there's actually a recommendation that everyone get a second mRNA vaccine anyway, so it's sort of turned into a 2-dose vaccine. And then for immunosuppressed people, they're recommending at least sort of a second mRNA dose and potentially a booster. So it's kind of turning into the same number of shots at the end of the day. So at this point, I just say get a Pfizer vaccine or a Moderna vaccine. So we do have good data showing what happens to people with IBD on various medications in terms of vaccine responses. This is from the UK group, and they have a great study that shows that patients on infliximab have lower vaccine responses. In the green is the infliximab, have lower vaccine responses. You can see the black bar there, compared with patients on vedolizumab. And that's not, super surprising, but overall, again, from the Secure IBD registry, 95% of people with IBD who who have had an mRNA vaccine, so both vaccines, show evidence of an immune response by blood titers. So this is actually pretty profound because we recommend the flu vaccine all the time, and really only 70 to 75% of people actually mount a response to that in their blood. So this is a phenomenal vaccine by all measures. The lowest vaccine responses were seen in patients who were on an anti-TNF agent in combination with the thiopurine. That's still 88%. So as vaccine responses go, that's still pretty good. And what you might also see here is that on vedolizumab monotherapy or ustekinumab monotherapy, vaccine responses are very high. So, you could make an argument to not really consider them immunosuppression for this. But when I have my patients on Entyvio or Stelara ask me if they should get a second dose or, second booster, I'll definitely say just go ahead and get it. It feels safer. So this is a meta-analysis globally of not just the mRNA COVID vaccines, but including the viral vector vaccines. And it shows, again, that in a cohort of nearly 10,000 people with IBD, vaccinations, if you complete the full recommended series, are actually quite effective even on anti-TNF agents and immunomodulators. And because of the slightly lower vaccine responses seen in patients with IBD compared with non-IBD people, there are, with the mRNA vaccines, as I already told you, there's kind of a recommendation for more than 2 doses. And what you see here from the Secure IBD registry on your left is people who've received 2 doses, and then on your right is people who've, the taller bars are people who've received that additional dose, and they have this higher antibody titer. So we're going to quickly gloss over treatments, mostly because I only prescribe one of them so far. But there are now a number of treatments for people who are not in the hospital and at risk for severe COVID. So in my book, if you have IBD, you're at risk for severe COVID, even if you're not on immunosuppressive medications, because again, we do know that patients on mesalamine and corticosteroids do actually have increased risk for severe outcomes. And so Paxlovid is the one that I've been using more. It seems to be more widely available, but these days I feel like I have at least one patient gateway message a day that my patient has COVID. They're often fine, thankfully, but at the same time, if they're on concomitant immunosuppressive therapy or whatnot, I will recommend Paxlovid, which is a combination of 2 antivirals. The big issue has just been pharmacy availability. So, I'll have someone from my staff call the pharmacy to make sure that they actually have it. It's meant to be started within 5 days of symptom onset, and that's the reason for you to know about it, because I've had a number of my patients say, oh, I didn't even know there's treatments, so I didn't think I had to tell you until, our next clinic visit. It is approved for people 12 years and older, and they used 40 kilos in all these trials, so that's where the 88 pounds comes from. And you shouldn't use it with serious kidney or liver disease, as with many of these antiviral medications. There is Lagevrio, and I've never actually used that, but also kind of within 5 days of symptom onset. And then there is a new monoclonal antibody, which is administered as an infusion. But again, I haven't actually used that either. And then I have had patients that have sent for remdesivir for risk of severe COVID as an outpatient. That can be done in an infusion center. Shouldn't be done if your kidneys really aren't working at all. But that was, again, pre-Paxlovid. So I mentioned this again, but Paxlovid, the other important thing to recognize is that it's actually this combination. So you have to take the 2 pink tablets and the white tablet and do that twice daily. And in patients and colleagues who've been on Paxlovid, they've told me that it does cause kind of severe GI distress. So obviously, if you have IBD, it becomes even more annoying. But I think it does. The data are pretty convincing that it can decrease your risk for severe COVID. And there are treatments for hospitalized people with COVID as well. And so obviously that will be determined by your team in the hospital. So we don't necessarily need to talk about that for too long. But I just want to kind of wrap up and say, I get asked a lot in clinic about, should I see my family for Thanksgiving? Should I go to Easter? What should I do? How do I handle this? And I think it's important to recognize the epidemic of social isolation, which has been prevalent in this pandemic, and I think will have longitudinal ramifications. So I try to encourage my patients to really use a lot of precautions. So, especially with the unmasking on airplanes, I ask all my patients to stay masked on airplanes, even though, I don't like masking just as much as the next person, but, stay masked on airplanes. It seems very reasonable. And wash your hands a lot. Try to avoid people who are actively sick. sick, and, really put it out there that you're at risk for severe COVID. And if you're sick, please don't come. If you have a fever, please don't come to the social gathering. But it is important to do family things and friend things and do what felt normal before. Maybe in a slightly different way. And so we try to talk through these situations a lot because I think they're important, and it's not just all about COVID. COVID, though, is, ongoing. The pandemic is not really over. So this is as of last night. There are over 500 million confirmed cases of COVID-19 worldwide, including over 80 million in the United States. And in the previous 24 hours, 600,000 confirmed cases. So these are people who are reporting that they have COVID, not people who are positive on a home antigen test. Globally, there's been over 6 million deaths from COVID-19, including nearly 1 million in the United States. And so, the pandemic is not really over, but we do have to find a way of adapting to change. And it is reassuring that we have new treatments and better ways of identifying people who are at risk and risk stratifying and mitigating. So that's kind of what I really mentioned to my patients, at least. Obviously, I'm not a COVID-19 expert, but, from an IBD standpoint. So if I've, kind of really put you to sleep in 15 minutes, the big pictures are that poorly controlled IBD and steroid use are the greatest risk factors for contracting severe COVID-19 infection. So I think there's a lot of urgency in controlling IBD disease activity and mitigating steroid use, and this is just reason, number 400 to do it. COVID-19 vaccines are safe and important for patients with IBD, regardless of treatment status. And I would say these days, if you have COVID infection, then call your doctor ASAP. I don't know if it's a primary care doctor or how many GI doctors are comfortable prescribing Paxlovid or one of the other medications, but it's important to let someone in the healthcare system know that you have COVID-19 infection kind of quickly within symptom onset. And overall, I would say, follow the data and the science because the misinformation pandemic is ongoing as well. So thank you all